All right, so this podcast is going to cover management of patients with musculoskeletal trauma. %60 of unintentional injuries are musculoskeletal, meaning when we have accidents, when we have falls, unintentional, car accidents, things like that are musculoskeletal. So wherever system you work in, whatever area you work in, you're going to either have patients with history of musculoskeletal injuries, or they're going to be seeing you for an acute musculoskeletal injury. Sprains and strains are more prevalent naturally. They're less severe than fractures. All of these things together are going to lead to an effect on patients' quality of life and their ability to perform ADL. So as a nurse, you're going to have to help them with those things. You're going to have to help them teach how to care for themselves with now their injury, whether they have a cast or they have traction or they had surgery, or they just have had something that needs to just have some time to heal. So here's some definitions. Strain, injury to muscle or tendon. Remember, tendons connect muscle to bone. So a strain is injury to that muscle or tendon from overuse, overstretching, or excessive stress. What are signs and symptoms of that going to be? Pain, edema, muscle spasm, ecchymosis, loss of function. They're all on a continuum graded first, second, and third degree. First being the least, second and third degree, being the worst. A sprain is going to look similar, except for it's an injury to the ligaments and supporting muscle fiber around a joint. So a strain could be to the muscle or the tendon. The sprain is really to a joint caused by a twisting motion or hyperextension of the joint. So ankle sprain is very, very common. People say, I rolled my ankle. Really, they overstretched that or hyperextended that joint and now have sprained it. The joint is tender and movement is painful. There's edema. They have disability, meaning they have limited range of motion or ability to move that joint. And pain increases during the first 2 to 3 hours. They might think in the first initial 10 or 15 minutes that they're going to be okay. And then as the hours go on, it gets worse and worse. A dislocation is a complete separation of a joint. So the articular surfaces of the joint are no longer in contact the way that they should. That can happen non-traumatic, so it can be more of a gentle dislocation. Doesn't mean the patient still is in excruciating pain and uncomfortable, but a traumatic dislocation is an emergency because now we have potential disruption of blood flow to the extremity, damage to the nerves. They needs to be treated ASAP. Remember that as the nurse, you're not the one who is going to be putting that joint back together or, putting it, reducing that dislocation, but you would support the extremity if they came into the ED until the provider was able to see them. RICE is the acronym that we use for all of our musculoskeletal injuries. What it stands for: rest, typically up to 72 hours. ICE, 30 minutes, 3 to 5 times a day, minimally on for 20 to 30 minutes, off for 20 to 30 minutes. You'll see varying references on that. Compression, wrapping it with an ACE wrap is what's going to provide compression most typically. Shouldn't be too tight because we don't want to cut off circulation, but it's going to help reduce swelling along with the elevation. All of those are going to reduce blood flow to the area, thereby reducing edema, which can actually cause more pain and can compromise blood flow, like we talked about with compartment syndrome. So our interventions besides RICE are also going to be CMS checks, checking that color, motion, and sensation. Will provide to us that they have good blood flow, that their neurological system is intact. Anti-inflammatory medications like ibuprofen, Motrin, Aleve, to reduce swelling and reduce the pain. And then on top of that, they may need stronger pain management with opioids or narcotics. Bone, incomplete is only partially closed or a simple fracture does not break the skin. An open or a compound fracture, of course, is open through the skin, and the number one thing we said can happen to these patients is infection, because now that wound is considered a dirty wound, and very, very likely they'll need to be on prophylactic antibiotics to prevent them from getting a full-fledged infection. Comminuted is a bone that's broken into several pieces, and we'll see these pictures on the next slide here. So there kind of talks you through the ones that we just looked at: complete, across the whole bone; incomplete, partially; closed or simple; non-displaced, so the bone is like still lined up, versus displaced over here. It's no longer lined up, but it's still closed or simple because it hasn't opened the skin, versus our open or compound fracture there. This one, avulsion, we don't need to really know a lot about. Comminuted is all those little broken pieces. A compression fracture is only in the spine, so it's compression of a vertebral body. Typically happens in older patients as their bone density decreases. They're more likely to get compression fractures or some sort of traumatic accident for younger people. A depressed fracture only happens in the skull, which of course is going to lead to risk for increased intracranial pressure. Green stick is a incomplete simple fracture that is broken on one side and bent on the other. An oblique is kind of not a lateral, but more at an angle. And then a spiral is just that. The bone is actually in a spiral. It's from a twisting motion of the bone. Typically, we think of that in child abuse. So if we see that, we need to look at other factors to see if we suspect child abuse, or it can happen a lot from skiing or snowboarding injuries, because the ski gets stuck in the snow and the bone continues to kind of twist around. And then impacted is from pressure on the ends of the bone and kind of pushes it over top of itself. How are these patients going to feel? Muscle spasms after about 20 minutes. Typically, that's what actually causes them to have the most pain. So we need to be cautious. We need to treat those. We need to give pain medications, and maybe muscle relaxants. Something like cyclobenzaprine is going to be very, very helpful. We also are going to use our RICE interventions to help with that as well. They're going to have loss of function. You're going to see maybe deformity of the joint or the leg or the arm or whatever extremity it is. You might see one leg shorter than the other. And of course, you're going to start to have edema and swelling. Emergency management. So in the field, or the patient presents to the ED, immobilize the body part. So you might use a splint, where you use some sort of support across the joint or across the fracture, and you're going to stabilize it on both ends to prevent that fracture from causing more damage to the extremity. You're going to assess neurovascular status before and after splinting, because you don't want your splint to actually be a problem and lead to decreased blood flow to that extremity. If it's an open fracture, we're going to cover it with a sterile dressing or the cleanest thing that you have. If that's a towel that's been laundered and is clean, and that's the best we have, we want to cover it to reduce the chance of more microorganisms from finding their way into the wound. We, as nurses, do not attempt to reduce the fracture. That is an MD or a provider who will be doing that. Leading right into then management, the first thing that we need to do is reduction. What is the number one priority during this? Pain management, keeping the patient still, and getting good realignment. So if it's closed reduction, that means we can't see the break. The break is underneath the skin. The provider will manipulate the bone back into place and likely take an x-ray of it to ensure that the pieces are back where they need to be. If it's an open fracture, then they'll surgically, if it's an open reduction, it doesn't always have to be an open fracture to require open reduction. If it is an open fracture, then yes, likely we will do an open reduction. But if it can still be a closed fracture and require open reduction, just because we can't, there's multiple pieces like you're seeing over here, something like B, C, all of these would require potentially open reduction because they aren't going to line up very easily. We're going to need to use screws and rods and plates to do that. Then we are going to immobilize the fracture. So we either are going to immobilize that internal or external fixation if it's been an open reduction. So internal fixation is what you see in this picture here, right? Rods and screws. External fixation is what we're going to see coming up. The number one complication from an open fracture is, of course, infection. So here's a picture of that external fixation device, most typically used when we have extensive soft tissue damage. So this patient here has a clearly extensive wound to his leg, who's required lots and lots of healing, if we were to open them up, put an internal fixator on there, and then try to cast that extremity, there's going to be so much swelling and wounds. We couldn't put a cast over that wound there. It wouldn't heal. We wouldn't be able to see the drainage. We wouldn't be able to take proper care of it. So we need to be able to see these wounds and take care of them. Psychosocial nursing diagnoses, of course, disturbed body image. These patients have huge issues now that they have this external fixator on. Fear, right? How am I going to take care of this? How am I going to get around? If I'm an adolescent, are my friends going to be accepting of this? Is anyone going to come see me? Mobility, once they're out of the initial phase, they actually can bear weight on this to some degree. So we need, as nurses, to understand when and how that can happen and how much weight they can bear. Then we're probably likely talking about teaching them how to use cane, crutches, or walker. Pin care, it has to be cleaned. This is a pin or a rod going through the skin into the bone. We have to decrease the risk for infection. So once a shift, typically, we are going to clean these pins with either sterile saline, half peroxide, betadine, something to reduce the risk of infection. One sterile Q-tip per pin. You might have to use more than one if it's really gunky, clean it, get it rid of it, and then get another one to really make sure you've done a nice job cleaning it. What are we going to do once we either do internal or external fixation? Typically, once we have, opened or closed reduction, followed by internal external fixation. Just to kind of say that again, when a patient has a fracture, the first thing we need to do is reduce that fracture. If they have an open reduction, then they're going to have internal or external fixation. If they have closed reduction, likely that's going to mean they need to have a cast. So we haven't opened the skin at all, and then we're going to cast it after they have reduced it, meaning they realigned it, and now we're going to cast that extremity. We can cast arms, legs, we can do body casts, we can do hip casts, we can do all sorts of casts. And then, of course, they're made out of fiberglass or plaster. Pros and cons. Fiberglass, pros, it's lightweight, it's water resistant, it has a quick dry time. So those are all really great things. If it also has a water resistant dressing underneath it, they can shower, they could swim, they can get that wet. Not usually for hours, they shouldn't have it in the water, but they could do it for short periods of time. But it's more difficult to contour, so it's harder for the provider to get a really good fix on that. It just doesn't contour as easily. So plaster, which has been around a lot longer, is easy to mold, and so they get a really good fit on it, but it gives off heat as it's drying. So we have to warn the patient about that. We have to talk them through that and understand it's going to get warm, but it shouldn't burn you. So if it's getting so hot that it's uncomfortable for them, we need to assess that. And it can take 24 to 72 hours to dry. And during that time, we have to be really careful to make sure that we don't disrupt the position of the extremity that needs to be in alignment. Education, so go to your Taylor Skills books. Skill 19.6 and 19.7 are really, really helpful in this, giving us some more information about this. Before cast application, what are we going to teach them? We're going to teach them about what to expect during cast application. We're going to teach them about how the provider is going to do it. We're going to medicate them appropriately. If it's a child, we're going to be talking with the parent. During cast application, we need to talk to them about holding still. We need to be calmly using our therapeutic communication during that to talk with them. We need to mention the temperature. So it's going to feel warm if it's a plaster cast. Expect that. If it gets too warm, please tell me. Let's talk about it. And after cast application, we're going to be really, really diligent for several days assessing the CMS checks and assessing for the 6 Ps: pain, pressure, pallor, pulselessness, paresthesia, and paralysis. All of those things are going to tell us the patient has good blood flow and good nerve conduction through that extremity that's underneath the cast. Because for a couple of days that arm can keep swelling, it could be 36 hours later that now their fingers are blue and tingly and they have loss of sensation there. It's not going to happen necessarily right away. So what are some complications of fractures and casts? We're going to talk about some of these. We're not going to really talk much about delayed union or non-union or avascular necrosis. Delayed union or non-union is just that. We casted the extremity for 6 weeks and we took an x-ray of it, and for whatever reason the bone is just not healing appropriately. The provider will have to kind of figure out what the next steps are. Could be some bone disorders, could be dietary deficiencies, could be that the break was just really extensive, they need surgery. There could be a lot of different things going on there. So the provider will deal with that. Avascular necrosis is just that. Because of a lack of blood flow, the joint or the bone has become necrotic. Typically that means the patient needs to have surgery with a joint replacement, or we need to take out that bone. So that's pretty heavy duty. That usually happens pretty quickly after the injury. So we'll talk a little bit about disuse syndrome. We have to keep the muscles strong, or as strong as they can be underneath that casted area. So we can still do like hand pumps with a stress ball to help keep the muscle underneath the forearm cast. You can still do upper body strength when you have lower extremities. You can still use like your quads and your hip muscles, even if you have a foot that's booted. So really just trying to maintain good muscle strength in every place that you possibly can with the cast on. We're going to talk about fat embolism, compartment syndrome, and pressure ulcer coming up. So compartment syndrome is a complication of a fracture or a cast, or can just occur related to a musculoskeletal injury. So sometimes even in a joint or even in a hand or an arm, when we have injury to it, there becomes so much bleeding and swelling underneath the skin that eventually the skin is pulled as taut as it can be, and then the pressure has nothing else to do but kind of go inward on the blood vessels. So these patients are going to have decreased blood flow to the distal part of wherever the injury is. They have risk for ischemia, and irreversible neuromuscular damage can occur. How do you think these patients are going to feel? They're going to have an impairment to their 6 Ps. You can see that foot there, right? It's purple. It's going to be cold. It's swollen. It's probably tingly or has some paresthesias to it. Classic signs and symptoms of compartment syndrome are pain that is not relieved by opioids and increases with passive range of motion. Classic definition of compartment syndrome. Here's a picture of what compartment syndrome would look like. So here's like normal size of blood vessels and nerves in the middle of the forearm. So here's the fibular and the tibular bone. And so, leg. Over here, now you've seen that there's been some damage to this area right here. So there's bleeding, right? And there's swelling. And all of that has extended this extremity out far. That skin can only stretch so far, so now the pressure has started to be exerted inward on these blood vessels here in the middle. Treatment, well, if there's a cast that's causing it, and so the skin, everything can't swell out because the cast, we need to take the cast off. And by we, I mean we need to contact the provider and tell them that the patient is experiencing impairment to their neurovascular system and they have compromised blood flow. The provider will assess them and discern that. Also, if there's no cast that's causing it, it's just simply that the skin can't stretch any further, we're going to do a fasciotomy, which is what this picture to the right is showing us. We're actually going to cut the skin open, and it's going to allow the pressure to come out of those wounds and thereby alleviate the pressure, the inward pressure on the blood vessels. In this case, we want to elevate the arm exactly, or the extremity at the heart level, because if we put it up above the heart, then we are making it harder for blood flow to get to the extremity. If we put it down below the heart, then we're encouraging fluid to accumulate there, which also is going to potentially impair blood flow. So right at the level of the heart is going to be most valuable to these patients. A fat emboli is another common complication. 88% of all fractures develop fat emboli, but very few actually go on to develop fat emboli syndrome. What happens in a fat emboli? Well, when we break a long bone, especially, that bone marrow, which has become yellow bone marrow, so it's kind of a fatty bone marrow in the middle, can actually leak out into the tissues, be absorbed into the bloodstream, and then goes on to basically be like a blood clot. It can go up into the lungs and prevent blood flow to a portion of the lungs. So it typically happens 12 to 72 hours after the injury. And the classic triad of symptoms is hypoxemia slash tachypnea. So we have respiratory symptoms. Then we start to have neurological compromise, either related to the hypoxia, or we could actually even have a fat emboli go to the brain. And then a petechial rash, typically is on the chest, occurs 48 to 72 hours post-injury. So it's not going to happen necessarily right away. You would see these other signs and symptoms that the patient had a fat emboli. Really supportive measures is what we're going to do, and the provider is going to make some determinations about what we can do to support their respiratory system and give them oxygen, of course, probably ventilate them so that their hypoxia is relieved. Pressure ulcers can be very common under a cast as well. This picture here is showing you some of the locations where pressure ulcers could be. The patient will likely complain to you that they have a hot spot in their cast. So that would be the first indicator that we suspected that there was a pressure ulcer. So we would need to either take the cast off, we need to cut a hole in the cast, and really what our job as a nurse will be is to report these findings to the provider, and the provider would figure out what we need to do. Traction is another thing that we will do if patients have fractures. Either do this as a short-term intervention while they're waiting to have surgery. Very typically in our hip fractures, we can use this. And then not as commonly, we'll use it after surgery to stabilize the fracture. Maybe they need another surgery, or maybe we need to wait to cast them or something like that. So what is the definition of traction? The application of a pulling force to a part of the body. The whole purpose is to reduce muscle spasms, which we said way back a few slides ago, that muscle spasms are one of the things that cause the most pain in our patients that have fractures. Reduce, align, and immobilize the fracture, reduce deformity, and increase the space between those opposing forces, which is where the fracture is. Here it kind of really shows you about the vectors of force and the lines of pull, and creating where we put the traction where we want the resultant line of pull to be. This is classic skeletal traction. I'm also going to show you skin traction or bucks traction, which is with a boot, and that literally just pulls the leg down and separates. Likely a femur fracture is what we would use it most commonly for. Here's a picture of that. So the nursing responsibility often is to set this whole thing up. That's an attachment at the end of the bed there that goes on. We would get that from central stores or from our supply cabinet. There's a pulley system there. There'd be a prescribed amount of weight. We would put the boot on the patient and apply the traction. If you ever thought that they were having an impairment to their neurovascular status after the traction was applied, we would call the provider to assess that. We would look and see, do they have good CMS checks? Are their 6Ps intact? Pain, paresthesias, pallors, are they complaining of any of that? And that would tell us. Typically in bucks extension traction, there's an order to take this off at increments throughout the day to provide cares, but you need to make sure you have an order for whatever that is, or there's a policy for your institution that dictates anybody who's in bucks extension traction, you can take it off, and do that. You of course want to be looking at their skin because you can't see that leg, you can't see that heel, so we have to be cautious of that. Here's skeletal traction. So there you can see like pins in his leg and the ultimate resultant line of pull. This is much more complicated than bucks traction. See, there's multiple pulley systems there. This is more of a long-term thing. Surgically, they would have had to put the pins into something like this. We would have to do pin care on this patient. So the same pin care that we would do as an external fixator. We need to absolutely make sure that this stays on at all times. The patient's body weight typically is what is considered the counter force. So we put the weights hanging off the end of the bed, and the weight of the patient laying in the bed is the counter force to those weights, thereby reducing or creating that pull between them. Skeletal traction is never, never, never interrupted. Weights are not removed unless intermittent traction is prescribed, and typically that's only for our bucks traction. So we need to make sure the weights aren't sitting on the ground. We need to make sure the foot plate on that box traction isn't hitting the end of the bed. You need to make sure that the ropes haven't broken. You have to be assessing that traction at very frequent intervals to make sure that the traction is always, doing what it's supposed to be doing. So preventive interventions, we need to be doing CMS checks and neurovascular checks very frequently, usually typically Q-hour or Q2 hours on these patients. Frequent back care and skin care because they're going to be laying in the bed, and regular shifting of positions. So we might not typically be able to put them all the way over on their side and reduce the weight, but you might be able to just position them a little bit differently to reduce pressure. Best case scenario, we get a special mattress and or some other pressure reduction device. Perform active foot exercises and leg exercises every hour, preventing DVTs. We want to help with skin issues, and we don't want them to lose strength. They might need to get up from this surgery and use a cane, a walker, crutches. We need to be thinking about those things. They need to have TEDS hose, pneumatic compression devices, more than likely anticoagulant therapy, because we can't put TEDS hose or compression devices on the leg or extremity that's in traction. The trapeze to help with movement for patients. They can use that to move themselves off their pressure and reposition themselves frequently, as well as maintain or at least help their upper body still have some strength. It's not going to be enough to just use the trapeze to maintain body strength, but it certainly isn't going to hurt. Pin care, same rules apply. Every 8 hours, 1 sterile Q-tip per pin. So here's all the things that we're going to assess. I think we already talked about neurovascular status, but also respiratory. They're going to be at risk for pneumonia, atelectasis, constipation, nutritional problems, urinary stasis, and UTIs. They might be having to go on a bedpan so they can't empty their bladder all the way, which is going to put them at risk for a urinary tract infection. Emotional behavior responses to being in bed and being on bed rest, and how are we going to cope with that? And what if I was an Olympic athlete and now I have to be doing this and thinking about this injury, and how is this going to impact the rest of my life? Knowledge deficit on all of these different devices that they're now have to have, and who's going to take care of me, and what's going to happen after I don't have traction anymore. Are they going to need a cast? Lots of things to consider. So I sent you on your way the other day to do 1-minute care plans. So pull those out, use them, do another one, work through the nursing diagnoses for these patients. Some examples: deficient knowledge, anxiety, acute pain, self-care deficit, impaired physical mobility, skin integrity, risk for infection. We kind of talked through a lot of these already. Self-care deficit, helping them to do what they can do, right? They can still wash their face. They can still brush their teeth. Let them do those things. Help get physical therapy to come in and do exercises with them. You then continue the exercises throughout your shifts. Once an hour you go in and have them do their arm exercises and their leg exercises on the opposite leg. All of our nursing interventions geared at skin integrity and risk for infection, turning and positioning them, incentive spirometer, coughing and deep breathing, increased fiber diet to decrease risk for constipation, fluid intake, high calorie, high protein meals to help with wound healing, and high calcium to help with bone healing. I think we just kind of ran through most of these interventions here, but if I was studying for this exam, I would really think about nursing diagnoses for each of these. And you don't got to memorize the nursing diagnoses, but it should come easy if you know what the goal is and what the interventions are, right? It should really be guiding what we know about these patients.